don't think adjuvant therapy is going to stand the test of time, and therefore for many patients, IMvigor11 may not be relevant. There is a need to identify patients at risk, and I think circulating tumor DNA does that really accurately, irrespective of whether it's the neoadjuvant case or the adjuvant setting, and irrespective of whether the patient is having neoadjuvant immune checkpoint inhibition or adjuvant immune checkpoint inhibition. And indeed, remaining ctDNA positive in the face of systemic therapy is really bad news, because that means treatment's failing. I think this is an interesting concept, because actually being ctDNA positive post-surgery after EV-PEMBRO, it suggests you should be switching therapy, not giving the same treatment. I know that's really controversial, and that's very different from what IMvigor11 tells us. What IMvigor11 tells us is when we can start adjuvant immune checkpoint inhibition, and indeed, it's predictive and prognostic in that setting. But this doesn't sound like the future, because we're going to be giving peri-operative EV-PEMBRO or neoadjuvant EV-PEMBRO and gemcitabine. And as I said before, it's telling us when we can start immune therapy, not when we should stop that peri-operative immune checkpoint inhibition. This makes the field complicated. And indeed, it's going to get more complicated as ctDNA methodologies improve and as we bring utDNA into this setting. Actually, further prospective utDNA and ctDNA trials are probably needed, especially with EV-PEMBRO, to clarify this issue slightly further. We've got a great tool. We've answered that question from a prognostic perspective, but we haven't nailed the perioperative predictive issue yet. We've only nailed the adjuvant prognostic and predictive issue, but I don't think adjuvant therapy is going to stand the test of time, and therefore for many patients, IMvigor11 may not be relevant.